Hi, this is Elliot Fishman, and welcome to part 4 of our series of talks on misdiagnosis in body CT. And let's start off with the kidney. The kidney has always been one of the great success stories in CT, but it also can be one of the most challenging areas where misses can occur unless we're careful. Things that become very important in making the right diagnosis, which means both detection of the presence of pathology and being specific, whether it's inflammatory or infectious or neoplasm, and often if it's neoplasm, is it papillary or clear cell or something else. Things that are important, the phase of acquisition, how we look at things, what display format, and whether or not we use 3D reconstructions. Now, if radiation dose wasn't an issue, perhaps you would get 4 phases on everybody, but it's an issue. So the key is to get as many phases as we need, but not more than that, but also to recognize that if you don't have the phases you need, you can miss a diagnosis or make the wrong diagnosis. So let's look at contrast CT and non-contrast CT. Let's start with non-contrast CT. The obvious thing is, if a study is a stone protocol only, you do a non-contrast CT. The thing about a non-contrast CT, it's really good for detecting a stone, but you can miss lots of tumors if they don't distort the outline. You can't judge function. There's so many things you don't get on a non-contrast CT, but you do get the presence of calculi. It's also good for looking at the initial value of a renal lesion. So, for example, if a lesion measures 85 Hounsfield units and is well defined, it's probably a high-density renal cyst. If I showed you only venous or arterial phase imaging, you would see 85 Hounsfield units and say, aha, I'm dealing with a hypovascular tumor, probably a papillary. So that becomes very important. Remember that people still write articles that 25% of patients with tumors under 4 centimeters that go to surgery are benign, and that's a very common cause of that. And again, if you know something's a high-density renal cyst or it's a simple cyst, you don't need to give IV contrast to make that diagnosis. So let's look at some of the things. Also, as I tell you, as we look through this, I will agree that there is no one perfect phase for all renal pathology or all renal masses. Each phase has advantages, and we discuss this in great detail in our lectures on the kidney. Now, again, with stone protocols, when a patient has hematuria and the stone protocol is negative, it doesn't mean the study is negative. It means the stone protocol is negative. And I like to make that point because in the ER setting, if someone calls down and says, hey, the CT is negative, they're going to discharge the patient and not worry about it. What you need to be able to say is, and I'm not a hedger, but you need to say is, look, there's no stone. But if hematuria persists, this patient needs to be worked up for hematuria. Remember what stone studies can say and what they cannot say. Very, very important. Non-contrast scans will miss small renal tumors, a tumor that doesn't change the contour, for example. It'll miss pyelonephritis in many cases, and miss most vascular pathology, including AVMs. This was a patient from the ER, stone protocol, hematuria, negative. The patient wanted to be discharged. When you give contrast, look at that 2-centimeter papillary renal cell carcinoma. There was no distortion, there's no change in texture here, but there's an obvious tumor when you give contrast, and here it is as we go from arterial phase to excretory phase. You can see it obviously in both phases. On the non-contrast, you would have missed a tumor that can get a partial nephrectomy and cure the patient. Again, no one perfect phase. Look at this case, that small renal lesion left kidney. All of a sudden, you're going to look at it and say, oh, what could this be? It's not a cyst. But that little dot there is very important. If you measure that little dot, it measures fat and has a mean of -71. One of the things that's commonly resected are angiomyolipomas. Now, a classic AML with lots of fat is not going to be resected unless you intentionally resect it because it's large enough and you're concerned for bleeding. But it's these punctate zones of fat. Here you just kind of look at it and say, oh, maybe there's a little cystic component in a solid mass. If you gave this patient contrast, look how vascular the lesion is. You would say, surely this is a renal cell carcinoma with that vascularity, unless you realize that dot is fat and you're dealing with a lipid-poor angiomyolipoma, which is a leave-alone lesion. We're doing some work with cinematic rendering to try to show this better. It's not quite there. What about display format? We know that you have to look at coronals and sagittals, and here's just a good example. This was read as negative, but look at the left kidney laterally. You see the cortical medullary interface looks a little different here. Well, you wouldn't be thinking about it if you looked at the coronal view because there was a 3-centimeter hypervascular clear cell renal cell carcinoma. Things can be missed on one view. Looking at the axials only is great, but this is a good example of showing how easy it is to miss something. Or in this case, the person reading this assumed this was the upper pole of the kidney and was normal, while it's a tumor in the upper pole of the kidney. Again, it's how we look at things that become very, very critical. And you need to, even if the kidneys look normal, look at the coronals especially, but look at the sagittals as well. We also talk about mimics, and this is in a very specific lecture on mimics in renal masses. Things like pyelo, XGP, infarcts, and IG4-related diseases are all possibilities. Here's a good example of non-contrast scans where the kidney on the left is enlarged and there's stranding present. You're not going to read that on a non-contrast as negative. It could be an infarct, it could be infection, could be even a tumor theoretically. Once you give IV contrast, you see the patchy enhancement in the left kidney. You see the stranding around the left kidney noted. Looks mass-like, and again, sometimes pyelonephritis can be confusing because it can be very mass-like. This was a case, you checked the urine was infected, E. coli infection. This was acute pyelonephritis. I like to show this case, particularly the image on the right, showing you if this was the only image you had, you might say, haha, this is a 4-centimeter papillary RCC. Remember that tumors and infection can indeed overlap, and why multiple phases make your life easy. Here's that same mass, which is really an inflammatory mass in the coronal plane. I also speak about the ureter in the kidney talk or our lectures on hematuria. It's important to recognize you need to look at the ureters carefully. It's very easy when just scrolling through the images to miss strictures, miss small tumors, miss infection, and even miss stones. So you got to look very carefully. Here was a patient, we're looking for hematuria. We were taking the bone away, and I noticed the ureter here, which is not dilated, looks like a donut. If you look at that more carefully, what is in that donut? It's actually a small tumor in the ureter. We always like to think about ureteral tumors. You'll see obstruction, so the ureter will be dilated. You're looking for transitions from normal to dilatation. But this case shows you very nicely a 2-centimeter mass did not obstruct the patient's ureter. If you weren't careful, you would miss it. This case also makes the point when you look at the kidneys and surely the ureters and bladder, things get very dense, particularly on excretory phase imaging. Make sure you widen the window. Typically, we do a window width of 410 over maybe a center of 7. Go to 550 over 50. That will be very helpful. We also like to recommend MIP imaging. MIP is really good for looking at the calyces and ureter and showing you that tumor from the case we just looked at. Again, there's no hydronephrosis, but look how obvious the tumor is on the MIP images right there and there. Now, we wrote this article, Shiva Raman and myself, a number of years back, talking about the challenges of missing ureteral tumors. Again, you need to be very careful. MIP is very helpful. You need to really scroll very carefully in coronal and axial plane. I do believe that the use of 3D, especially MIP, is an easy way of doing things. I think the 3D with volume rendering needs the radiologist to be involved. The MIP imaging, you can have the computer pre-generate MIP imagings and just scroll through them very much like you do with chest for PE. I think that's very valuable. Here's an example. Left kidney in a patient with hematuria. The left kidney, the pelvis looks fuller and maybe there's some irregularity of the renal borders. With contrast, it doesn't enhance as good or as well as the patient's right kidney. You can see there's some stranding by the pelvis. And when you look carefully, at first glance, here's ureter, Do you worry about this left ureter? Is that partial averaging? When you look at the reconstructions, you see that there's a dilated renal pelvis on the left. Maybe it's a UPJ. What's going on here and what's going on here? Well, you do get, the ureters do have peristalsis, and so it's hard to get the ureters routinely filled, even if they're a little obstructed. This actually is normal ureter, and normal ureter, this actually is due to tumor infiltration. When you look carefully, again, we'll look carefully at those areas. Here we worry more because the calyces are dilated. I have to worry there's something going on in the pelvis or the proximal ureter. And there it is when you look at the left kidney. You can see there's soft tissue thickening of the proximal left ureter. That was an infiltrating ureteral cancer. Again, it's subtle, easy to walk by. The dilated calyces do help you out in this case, but the MIP imaging is particularly helpful, as is the curved planar reconstructions. Another example, looking at this case, you look at the kidneys, they both look pretty good. The ureters as visualized look okay, but when you have that routine MIP on the left ureter, look how irregular it looks right here. Look at the right ureter, it looks perfect. Now there's no hydronephrosis here, there's no dilatation of the ureter, but this looks ratty looking, and that ended up being a transitional cell carcinoma. Again, the MIP imaging is the only reason you suspected that finding. Very nicely shown on this study. Another example, dilated ureter maybe on the left side, or is it normal? You keep scanning downward, and there's the left ureter, but it's like a semicircle. What's going on there? Now you see a filling defect like the first case I showed you, kind of that donut appearance. And there it is. You picked up a 15 millimeter TCC of the ureter. You can resect it and cure the patient. If you don't pick it up, the patient will, in a couple of years, present with hydronephrosis and likely tumor spread. Look how subtle these cancers are. To me, it's very concerning because it's so easy to miss these when you're very busy. When you're evaluating patients with hematuria, look carefully at the kidney at multiple phases. Look carefully at the ureter. Look carefully at the bladder. And use techniques from coronal reconstruction to MIP imaging to volume rendering to help improve your accuracy. That indeed becomes very, very important. And here it is nicely on the MIP. There's an obvious lesion there. Wasn't so obvious when the person read it at first as negative. Now let's look at some other things. Let's leave the kidney and go to mesenteric vessels. And I want to speak about the importance, which we've really enforced for many years now, and people are doing it more frequently, about looking beyond the axial images. And what we showed is if you only looked at axial images, you missed a lot of routine pathology in the celiac and SMA. Now, I know and everyone knows if you're looking at pancreatic cancer for staging and vessel involvement, you look at that. If you're looking for median awkward ligament syndrome, you have to look at the sagittals. But I mean routinely. You will miss lots of pathology. You can miss occlusion of the mesenteric vessels, particularly when it's distal. Mesenteric vessel occlusion can lead to ischemic bowel. It can be due to arterial thrombosis or embolization. It's interesting with embolization, it's usually the mid-vessel, and the proximal vessel is due to atherosclerosis or thrombus. Good example here, patient with abdominal pain. Celiac and SMA look pretty good, a little bit of narrowing by the celiac, but look how good the SMA is. There's no plaque, but as you go further down, there's clot in the vessel. It was an embolic clot, and this patient was developing ischemic bowel. Look how nicely it is on the sagittal, and look how nicely it is on the MIP imaging. MIP is really good. You lay the vessel out. I love looking at MIP for looking for vasculitis, for fibromuscular dysplasia, for thrombus, and for tumor involvement. When you look at the MIP, you can scroll in and out and get any plane you want. Here, very nicely showing you the thrombus. It's very important, and I use this quote all the time, when you're looking for ischemic bowel, look at the entire vessel. You know, people tend to focus on the proximal aspect of the vessel, yet as in the cases I just showed you, the clot was distal. The midline sagittal view is so important, whether it's SMA syndrome or vascular stenosis, median awkward ligament syndrome, staging pancreatic cancer, looking at aneurysms or collaterals, the sagittal view is critical. This was read as negative, but look at the SMA. We think about FMD as in the renal arteries, but here it is nicely involving multiple branches of the SMA. Here's another example. And in this case, you could see that the patient also had small aneurysms present. Here as well, multiple aneurysms in branch vessels of the SMA in a patient with fibromuscular dysplasia. Here is another example using cinematic rendering showing you the irregularity, the beating of the branches of the patient's SMA. Very important. You're not going to appreciate that if you only look at axial imaging. The next thing I want to look at, and I think what I'll do is I'll stop here and we'll do one more session where we'll look at bone and soft tissue and reach some conclusions beyond that. And let's take a break and come back in 5 minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.